My name is Tim Gibbs. I'm one of your two co-hosts. Dr. Kate Smith is also with us. Delaware Mini Medical School has been running now since 2009, and we're very proud of the partnership that we've developed with ChristianaCare, the area's largest regional medical system. And we're going to hear from an expert from ChristianaCare this evening. I'll turn it over to Dr. Smith to go ahead and cue us up for the rest of the night. Over to you, Doctor.
Thank you, sir. Before I change my screen, I do want to point out that this is DelawareMiniMed.org, and that is where you're going to be able to find all of the recordings for our sessions. So this is the YouTube video, for example, from last week. This is the slide deck that Dr. Bauer used, and these are the additional questions and answers that we didn't get to. So that is there, and you guys are, those videos and everything will go up eventually, hopefully before the next session, but I can't promise anything. I will do my very best to get that happening though. The next quick thing, this is week 2. We are going to hear about breast reconstruction and plastic surgery and some odds and ends. Again, please change your name to the full name that you registered with so that I don't have to figure out who Kathy's iPad belongs to. Please keep yourselves on mute during the presentation. We can ask questions at the end of the presentation. To ask a question, you can put it in the chat, or you can raise your hand and I'll call on you. The attendance, there was some questions about the attendance. I don't want to be that jerk that says, you know, no, you don't get attendance, but I can also not be the person who's spending 5 hours going through 400 people on Zoom trying to figure out who's here and who's not. So in order to be counted as having attended, you must either put your name in the chat, as a lot of people are doing right now, or if you're attending on the phone, you can email me at ksmith@delamed.org by 9 o'clock tonight. So that gives you half an hour after the session ends with the word of the day. All right, either or. I don't need both. I don't need you to put your name in the chat and send me an email. If you're on Zoom right now, just throw your name in the chat. If you're on the phone, just remember you have to email me at the end. You can't email membership@delamed.org. You have to email ksmith@delamed.org. That way, if you've attended all 6, you'll get a certificate of completion or a certificate of attendance. I'm not giving out certificates to people who weren't here at 6:30 with everybody else. That's not fair to those people that did show up and did follow the attendance rules and got themselves here and able to listen and watch. They are available for later if you want to look at them again, or if you have a friend and family member who really wants to see it, that's great. But in order to get the certificate of attendance, you have to have been here and present all 6 times, unless you've previously made an agreement with me, like my emergency surgery is scheduled for Thursday at 6:30. That would be an okay reason to miss, but that has to be previously communicated to me, okay? I'm sorry, I don't want to be a jerk, but at the same time, I can't be getting emails for the next week saying, oh, I was there. So you have until the end of the session to put your name in, or you have until 9 o'clock tonight to email me the word of the day. If it comes in after 9 o'clock, I'm sorry, you weren't following the directions. We're all grown-ups, we can all follow directions. And honestly, I don't think that that's a difficult direction to follow. So tonight, our word of the day is CATS, C-A-T-S, CATS. And our presentation, as I said, is on breast reconstruction and plastic surgery. And our presenter this evening is Stephanie Caterson, I hope. Maybe it's Caterson, which is also awesome. I'm going to go with Caterson, so you tell me if I'm wrong. Dr. Caterson is a reconstructive plastic surgeon who specializes in comprehensive breast reconstruction, including advanced microsurgical techniques. She is the director of perforator breast reconstruction and leads the collaborative breast reconstruction program at the Helen F. Graham Cancer Center and ChristianaCare. Dr. Caterson has been practicing since 2007 and began her career at Harvard, Brigham and Harvard Brigham and Women's Hospital in Boston, where she spent over 12 years developing an internationally renowned microsurgical breast reconstruction program. There, she served as the director of perforator breast reconstruction and performed over 1,500 microsurgical flaps. Additionally, Dr. Caterson was the associate program director for the Harvard Plastic Surgery Residency Program and was honored with many exceptional teaching awards. While in Boston, Dr. Caterson was an integral surgeon in many face and hand transplant procedures with the vascularized composite allotransplantation team. She was also an essential provider for the victims of the Boston Marathon bombings in 2013, providing acute care and later microsurgical reconstructive procedures for limb salvage. Her bio goes on and on and on. So please feel free to check her out because she's amazing and lovely. And now I am going to stop my screen sharing and I'm going to turn it over to Dr. Caterson or Caterson. I wonder what I was. She'll have to tell me. Did I get it right?
Nope, Caterson.
Well, that's also awesome because that's my name. So that works out well.
Exactly.
I couldn't go wrong, really.
It's fine. I answered to pretty much everything. So there's no problem at all. I'm going to try to see if I can share my screen here with you guys. I somehow am not able to start my video. I've been clicking it a million times, but my screen should share. So I could log on my phone to show you my face if you'd like, but then I'm going to have cross-referencing with, I think, some feedback as I talk through the slides. So should I just share slides for now?
Yeah, just share slides for now.
Okay, let's do this. Hold on 1 second.
I did send a request to share video, so maybe that was it. I don't know.
No, I'm hitting start my video and it says failed to start the video camera, which is literally sitting right in front of me and has been on for the past 45 minutes.
Of course it has.
Yeah. All right. So here we go. Let's do this. And then let's do this. And here I will share my screen.
I will say, as far as attendance goes, if there's more than one of you watching, like if at home I'm looking at 2 people watching right now, if you both want credit, just make sure you put both names in. Okay. Okay. Yes, I can see it. You are good.
Great. Wonderful. Thank you. Okay, well, I will just get started here. I am so excited to be participating tonight in this year's mini medical school series, and I hope y'all find it interesting. I did a little outline for, where am I? Here I am, sorry. I did an outline for what we're gonna work through tonight. I was asked to share a little bit about my path in plastic surgery, and I will do that. And then I'll talk to you about the Center for Breast Reconstruction, which is what I've developed here at ChristianaCare, and then go into some details about what a patient would expect from a breast reconstruction consult, what options are available for breast reconstruction, and how we help patients decide on how to, what reconstruction is best for them. We'll do a general overview of all the major types of breast reconstruction, including some real life examples. So I'd like to just throw a little warning out there that there will be images of my patients that have given me permission to share these images, but it's of breast reconstruction. So there will be some photos of breasts. And also I'll highlight a really exciting area that we've started here at the Cancer Center, which is our nipple and areola tattooing techniques. So that's our outline for this evening. So I grew up just north of here in a small town called Lehighton, Pennsylvania. I grew up on a farm. It's basically in the Poconos. I spent all of my time outdoors, playing sports, fishing, hunting. I attended a very small local public high school where about, I think, less than 50% of the graduates went to college. I was a good student and I was interested in math and science. So I continued on to college and went to the University of Colorado. At the University of Colorado, I chose this school to go to, not because I am a lifelong skier, although that came in real handy, And also not because they have absolutely the coolest mascot in the world, which is Ralphie the Buffalo, who runs live at all of our football games. But I went to the University of Colorado because I wanted to be an astronaut, which it seems like an odd start to my talk about breast reconstruction. But at the time, the University of Colorado had the best aerospace engineering program in the country, and that was what I wanted to do. So I attended school there and took many classes on aerospace engineering. I ended up graduating with both a bachelor's and a master's in aerospace engineering. And during that time, I took a class from a mentor of mine called space physiology. And that really encouraged me to apply to med school because I loved the idea of the way the body changed in space. And my mentor explained that in order to be an astronaut, you needed some higher level education, a PhD or an MD, and he thought that that would be a great route for me. So it was a way to apply to the astronaut program. And I decided, why not? I'll apply to medical school. So off I came back east here to Jefferson Medical College. And I started medical school. I immediately felt fairly out of place. It was a very difficult transition to medical school because in aerospace engineering, it's all about problem solving. My tests were open note, open books. There was not a lot of memorization in engineering. It was really applying different tools to solve the problem. In medical school, the first 2 years is pure memorization. So it was a big adjustment for me. And as I tried to find my way, I was continuing to research the astronaut program, and I learned a few key things early on. And the first thing is that most physician astronauts did not complete a residency. So they did not go on after medical school to do any residency training. And to me, that didn't sit well. I felt as though I needed to do a residency, having gone to med school. So I didn't think that was going to be the route for me. I also learned that most physician astronauts who did do a residency trained in the emergency room, emergency department for their residency program. And I did an elective in ER and was so excited to do it. And from about 2 hours into my shift, I realized that this was definitely not for me. I was not cut out for the emergency room. So I was again in a bit of a quandary to how I was going to make these two paths come together. I was really gravitating towards surgery, and I thought, well, heck, how about trauma surgery? Maybe trauma and space, I could kind of make those two things meet. And turns out that trauma surgery, again, was not really meant for me. I didn't like the ups and downs of the day, the emergencies that came in, and then the days that were very quiet. I liked knowing my schedule a bit more. So I figured out a way to try to help make this decision. And what I decided to do was apply for a general surgery residency program. And at the time, I was becoming more and more enamored with plastic surgery. I'd done a rotation on plastic surgery at Jefferson and really enjoyed breast reconstruction in particular. I was part of, a flap operation where a woman went to sleep, with a breast cancer and woke up with her abdominal tissue, making her a new breast. And she was over the moon. And that was really a defining surgery for me as a medical student. So I liked that, but I really couldn't find any way in which plastic surgery could help me become an astronaut. So I decided, well, I'm going to do general surgery. And then when I do general surgery, I will apply to both the astronaut program and the plastic surgery fellowship at the same time. And then we're going to see who wins. So that was my plan. And I started general surgery. I was lucky enough to match at Jefferson as well. So I stayed on at Jefferson for my general surgery training. And in early 2003, I began the process of this application of both plastic surgery fellowship and the astronaut program. Exactly at that time, there was a space shuttle catastrophe. The space shuttle Columbia was returning back to Earth, and it disintegrated upon reentry. So the space shuttle program was suspended, and they were not taking any astronauts, and my path forward was fixed. So I decided that I would move forward with plastic surgery and continue down that path. So I finished my 5 years of general surgery training and applied for plastic surgery training. I was matched in plastic surgery fellowship and at the time, this was an extremely competitive fellowship. I was really lucky to be able to be offered a spot at the Leahy Clinic, which is just outside of Boston. I did a 2-year fellowship and I trained in all aspects of plastic surgery. I remained very inspired by breast reconstruction at that time. And while I was in Boston, I developed relationships during this fellowship, and I was actually able to help mold a Harvard-wide breast microsurgical fellowship. And I was the first fellow to train in this program. So following my plastic surgery training, I did another year of 1 year of specialty training in microsurgical techniques and breast reconstruction, which is really what I've built my career on since then. So I show this slide here just to illustrate that the breadth of plastic surgery. And, so when I first told my mom that I wanted to be a plastic surgeon, and she looked at me and kind of blinked, and I wish I had my video on now, because she said, "Honey, you don't even wear makeup." And I laughed and I said, "Well, Mom, it's not all about, cosmetic surgery." And, this diagram here really shows you all the different things that people subspecialize in plastic surgery. You can do general plastic surgery and do kind of everything that comes in the door. And a lot of plastic surgeons do cosmetic surgery, but there are plastic surgeons who only do breast reconstruction and microsurgery, which is me, as you can see here by these stars. There's people in plastic surgery trained who only do hand surgery, or the face transplant, composite, tissue transfer surgeries and things like that. My husband is a craniofacial surgeon, and I'll talk to you a little bit about him later, but there's many spokes to this wheel. Let's see. So I'm going to change gears for a minute here and discuss why I think breast reconstruction is so important. Breast cancer is the most common cancer in women. It affects about 300,000 new cases a year in the United States alone. And I think most of you have heard the statistics of 1 in 8 women will get breast cancer. So I think that reconstruction is an essential part of breast cancer care. And, the imagery of female breasts is very commonplace in our American culture. This is an ad from 1992 showing, Kate Moss. It's an ad for perfume, and, it was put out by Lord and Taylor. So this is as commonplace as it gets. It's in a magazine. And, yeah, I think that it demonstrates that, in the background of our lives, we really have ingrained what a woman's breast can mean to her. So I think, socially, a woman is often very worried about what her breast will look like from a beauty standpoint. Will she still feel beautiful without her breasts? Psychologically, it really affects a woman's sense of self-esteem or wholeness if she loses one or both breasts, or even has a breast surgery. Emotionally, it can affect a patient's, femininity, sexuality, their sensation, and, ability to enjoy these things. And also just really from a functional standpoint, if you have breast surgery, there will be scars, there will be, a healing process, and oftentimes breast reconstruction can help with those things and continue to allow women to, be symmetric and live a healthy life. So I felt like it's a very important topic that is surrounding the breast cancer community. And, breast cancer awareness is becoming more and more in the forefront of our world. In 2013, Angelina Jolie announced that she had undergone bilateral mastectomies with reconstruction secondary to a gene mutation. And I do think we call it the Angelina effect. And she virtually single-handedly made, this topic a household topic. And, people were discussing this at their dinner table. In 2009, the NFL and along with many professional sports began a breast cancer awareness and funding campaign. And you often see images like this in the fall during Breast Cancer Awareness Month in October of our professional athletes supporting breast cancer awareness. This is actually a very provocative new ad that came out last month on Twitter. And this is an advertisement for a new Adidas bra. And at the top of it, it says, "This is a bra for all shapes and sizes." And it was shocking to me because I have a slide very similar to this that I used in the past to illustrate the range of breasts in regards to breast reconstruction. And as I zoomed in on this, I was really thrilled to see that these two patients circled in or squared off here in red are breast reconstruction patients. So our Adidas ad included breast reconstruction patients, which is really great. This is the slide I had made of my patients, and I think also very demonstrative of the different of sizes and shapes. And though I thought a lot about what ideal means to a patient. And you can imagine that what an ideal breast shape means something different to every single person on this slide. So, I had to basically try to take a step back and consider more global goals for myself and for our patients when it comes to breast reconstruction. So I think an ideal breast, again, it's variable. It depends on puberty, on weight gain or weight loss or pregnancy or lactation, menopause, or the ever-present gravity. It changes over time. But when I think about, what are my goals for breast reconstruction, pretty simple. I would like for the nipples to be pointed forward if possible, not downwards or towards the ground. I'd like the breast to be a soft consistency. I'd like some symmetry between the two breast mounds. I'd like to maintain as much sensation as possible and to minimize the scarring on the breast. So these are my overriding global goals for breast reconstruction. And I do believe that breast reconstruction can sometimes, not always, but sometimes can be the silver lining of an otherwise very dark cloud for a patient. So, as an example of this, you can take a patient who's born with a congenital breast asymmetry, has a breast cancer diagnosis and a BRCA gene mutation, and you can give her improved symmetry and a lot of happiness. And when you can do this for a patient, I consider that to be a pretty good day. So I finished my fellowship and I moved on to my first job. And my first job was at Brigham and Women's Hospital, which, Kate very nicely described as she was introducing me. I was very lucky to have the privilege to develop a comprehensive breast reconstruction program at Brigham and Women's Hospital. I was the first person in that system to do the more complex microsurgical deep flap reconstructions, which we'll talk about tonight, and to grow the program over time. So I was there for, about 13 years. I did, over 1,500 flaps on patients, over 1,000 flap patients altogether. Some of them got 2 flaps, so that's why that number's higher. And then the collaborations that I developed as I worked there, I think was one of the most satisfying things of this program, really working with all of these different realms of people together to make our program, I think, one of the best in the country. By the time I left there in 2019, we had over 10 surgeons working with me doing these flaps for patients, which is exciting and also really kind of sad to think that there are that many people who need these procedures. So while I was in Boston, I also developed some personal experience, and I got married to this guy. So in medical school, I met my husband. His name is EJ. Our paths kept crossing and we eventually started dating. We followed each other to Boston and got married. He is also a plastic surgeon, a craniofacial surgeon, as I mentioned. So it's kind of fascinating having 2 plastic surgeons in one relationship. A person once told me that the ideal number of surgeons in a relationship is 0, and they're probably right, but unfortunately, that's not the case for us. And it was kind of interesting. A lot of people found it kind of, interesting as well, and wrote a lot of articles about us, which was slightly embarrassing. But we got to spend some time together in the operating room. This photo, can you guys see my my slide here. Okay, so this is us doing the one of the face transplant patients together. This is me teaching him when he was a fellow. I was an attending, teaching him how to do an operation. Here we're doing microsurgery together, and here we're just, I don't know, having some silly interview about Valentine's Day. But in addition to that, we're very fortunate to have these 3 little munchkins. So we had 3 boys in 3.5 years. They are spread out pretty evenly over that time frame. And living in New England, we turned them into skiers. So they're little shredders, real good on their feet. And we also turned them into Patriots fans. So I reluctantly put that up here in Eagles territory, but I think it's an important thing in our family. And in 2019, my husband was recruited to Nemours AI DuPont Children's Hospital to be the chief of pediatric plastic surgery. And we actually were lucky enough to convince ChristianaCare that I was worth taking a chance on. And with that, they allowed me to come here and start what I have called the Center for Breast Reconstruction at ChristianaCare. And it really, I am just so honored to be able to bring all of my experience to the Delaware community and grow something that I think is really important for our patients here. So that's what I've been doing since I came in 2019. So luckily, a lot of the components of which I think are essential for a successful breast cancer program were already in place at the Helen F. Graham Cancer Center. And, I really love this slide because it shows the bigger picture of care. And one of the things that I love about it the most is that all of these spokes of all of these different people who care for the breast cancer patient, they all point inward towards the patient. And that is really the feeling here at the Helen F. Graham. And, I'm just one little spoke there. But if we expand my spoke out to, this is my one little dot here in the middle, when a patient comes into my office, we talk about often all of these different options for the patient. So a consult in my office takes a long time. I'll talk to you a little bit of details about, what that looks like, but all of these different circles are things that we can do for a patient. We can do tattooing. We can do different types of flaps. We do different types of implant reconstruction. We can do a reconstruction for nipple sparing or not. We can do partial breast reconstruction. We can do flat aesthetic closures or revision surgery. So a lot of these things are covered with our first consult with the patient, which is about 2 hours long. So how do we get through that? How do you help a patient decide? And the short answer is it's really not easy. My approach is a multidisciplinary one, and I think that includes both my colleagues and the patient. So there are more than one option available for a patient that would be a good choice for them. So you see a patient in your office and you attend a multidisciplinary conference or clinic with your colleagues in breast surgery or in medical oncology or radiation oncology, and we come up with a treatment plan for that patient. For me, I'm talking a lot to my patients about their goals, their expectations, their lifestyle, and trying to decide how we can best achieve those goals for them. So this is a photograph of my office. When you come in for a breast reconstruction consult, it's about a 2-hour visit. And it starts with the history and physical. We do photographs of patients, which I'll be sharing some of them with you tonight. And then we discuss all of these options. Is reconstruction right for you? If it is, what's the best timing for reconstruction? And then what are all the different types of reconstruction? We'll schedule studies for the patients and also potentially schedule their procedure. So I think, we have to help patients that are coming to see me at times decide between should they have a mastectomy or should they try to preserve their breasts and do breast conservation. Now, sometimes that decision's made before they ever walk in my door, and it's made solely based on the recommendation of the breast surgical oncologist, to whom I always defer, of course. But sometimes the patient could choose either. And if they do, I often will be talking through the pros and cons of doing both. If they're choosing mastectomy, sometimes they might want one breast, sometimes they may want both breasts removed. We may be able to spare their nipple, or sometimes we cannot. We might be able to do an implant-based reconstruction, or we might have to concentrate on a tissue or a flap reconstruction. If they're trying to preserve their breasts, doing breast conservation or lumpectomy type surgery, I'm often involved in that patient's care as well by doing a procedure at the same time. The breast cancer surgeon takes out the cancer, and then I do a breast tissue rearrangement to get the breast looking in a nice shape again, and sometimes doing symmetry surgery on their other breast to lift or reduce that breast to match. So tonight we're really going to focus mostly on mastectomy, but just to try to give you a global overview of everything I do, this is part of that. So, breast reconstruction, is it worth the risk? And, this is the first thing that I talk about with a patient after I've done their exam and, we've gone through the photos. I say to them, let me tell you, you do not need to have reconstruction. Breast reconstruction is an option. It is not a requirement. And, this number varies, but across the country, about 42% of people who have breast cancer and undergo mastectomy also undergo reconstruction. So it's not even half. So I let them know that they do not need to do it. If they choose no reconstruction, they can also consider revision or contralateral surgery on the other breast. So maybe they better fit a prosthetic. So for example, of a patient who's a very large triple D cup breast and she wants a mastectomy and does not want reconstruction, I can do a reduction on her breast that's unaffected by cancer to help her better fit her prosthetic. If they do choose reconstruction, I reassure them that while there are a lot of choices, pretty much all forms of breast reconstruction have very high reported patient satisfaction. It's greater than 90%. So most people who choose reconstruction are very happy that they did so. This article that I'm referencing on this slide, I think it's also very provocative. It's called Going Flat After Breast Cancer. It's a New York Times article. And it was written, I think, to be somewhat of a devil's advocate opinion, but it interviews, I think, 5 or 6 patients who basically felt as though breast reconstruction was forced upon them by the medical community, and they felt as though choosing to go flat was a reasonable choice to do after a mastectomy, and they were, advocating for that for other patients. So I do share with my patients that it is a real option for them, and there are things that we can do to try to make that choice the best one for them. So if you're choosing breast reconstruction, or maybe the real question is, should we preserve your nipples? So I'll go through some of the things that I think about when a patient comes to me and wants an answer to that question. So the first thing that has to happen if a patient comes in with a breast cancer and they would like to have the nipple spared during their mastectomy, I have to have permission from the oncologic surgeon, the breast cancer surgeon, to say that that's a safe thing to do. How they make that decision is really how close the cancer is to the nipple. So if the cancer is right behind the nipple, it likely is involved in the tumor and it has to be removed. If the cancer is greater than 2 centimeters away from the nipple can often be removed, the nipple can often be preserved. We always do a little biopsy from right behind the nipple to make sure that the margin is clear, but they have to tell me that it's a safe thing to do. So after they say, yes, it seems like a reasonable thing for us to try to do, then the onus falls onto me to decide if from a plastic surgery standpoint, does it seem like a reasonable thing to do to try to spare that nipple? And the way I make that decision is all of these things on the slide. First, I look at the patient's breast shape and their nipple location. So ideally, their nipples, again, are facing forward. They have minimal extra skin. It is difficult to move the nipple later after you've done a nipple sparing mastectomy. So if your nipples are pointing in a direction in which you don't want them to be later, then they need to be removed and recreated. If their nipples are asymmetric, one's pointing, down and one's pointing forward, I'm not going to be able to fix that asymmetry if we do a nipple sparing procedure. So the only way to really fix that is to take the nipples off and to start from a blank slate. If a patient has a smaller cup size, they are a better candidate for a nipple sparing procedure. But the larger the breast gets, the harder it is to do that procedure and keep all the skin alive and to keep the nipple alive. And along those lines, if a patient's a smoker or has a history of radiation to the chest or poor skin quality, all of those things make them more of a poor candidate for trying to keep that nipple, because we have to be more concerned about the skin envelope. So this is just a little test here to look at the things that we just talked about. When you look at these patients across the board, who is the great nipple sparing candidate? And while this patient is small breasted, she has pretty significant stretch marks on her skin, and I think would like, and you know, this kind of papery type skin folding down here, I don't think that she would be an ideal candidate. This patient has already some significant breast asymmetry. This patient's very large breasted with a triple D cup and also asymmetry. But this patient, she's got good nipple symmetry, smaller breast, healthy looking skin. Out of all these patients, this is the only one who I would offer a nipple sparing procedure to if they were a good candidate from the cancer standpoint. So the next question that we're going to talk about are the types of reconstruction. So what are all of our options and what is the best choice for the patient? We're going to go into a lot of details as we go through this. So just globally speaking, I wanted to show one slide that really just listed all of the different types of breast reconstruction options. They're divided into two basic groups: implant-based reconstruction and tissue or autologous flap reconstruction. From an implant-based reconstruction standpoint, there are many options here. We can put the implant in directly, or we do a two-step procedure where we put in an expander and then an implant. We can put that implant above the pectoralis muscle or below the pectoralis muscle. We can use little matrices to kind of help support internally to shape the internal pocket of the implant. And sometimes we even have to add on top of this implant some muscle from the patient's back to give them a healthy reconstruction. From the flap standpoint or the tissue reconstruction standpoint, these operations all involve moving a person's body part up to the breast area and recreating the breast. So in these first 1, 2, 3, 4 options, it's using the lower abdomen to basically lift up that lower abdominal extra tissue below the belly button area and rotating it up to the breast area to make a breast. There's other options, moving tissue from the buttock area or from the upper or posterior thigh area to make the breast. So with all those options tonight, we're really going to mostly concentrate on the deep flap. It's DIEP or deep flap. It stands for deep inferior epigastric perforator flap. I'm going to talk about that in particularly because it really is one of the gold standards of reconstruction and kind of the state-of-the-art reconstruction at this point in time. I also put this no smoking sign up here to remind me to tell you that if you're an active smoker, you are not a candidate for any of these procedures. So just like I said, breast reconstruction is an option. It's not a requirement. If you have breast cancer and you can't stop smoking, I will be unable to do any of these reconstruction procedures on you because you will have a very high risk of having a bad complication that could set your health back. So it's my duty to help you with that. We have a lot of programs in place here at the Cancer Center to help people stop, hopefully permanently, but at least temporarily. They need to stop smoking 6 weeks before and 6 weeks after surgery to have a breast reconstruction. So this is statistics from 2020. The ASPS stands for the American Society of Plastic Surgeons, and they ask all the plastic surgeons in the country to report the cases that they do. And so we report them to the ASPS and they put them all together for us. And this pie here is demonstrating the different types of breast reconstruction performed in the United States in 2020. The big blue piece here is implant-based reconstruction, starting with an expander, a temporary device, and then later moving to an implant. This small piece here is also implant reconstruction, but it's going directly to an implant with no temporary expander phase. You can see that collectively, this implant-based reconstruction is about 80% of breast reconstruction across the country. So most people choose implant reconstruction. There's a lot of reasons for that. and we'll go into what the pros and cons of these different approaches are. But it's an important point to take home is that the majority of people, the vast majority of people undergoing breast reconstruction get implant-based reconstruction. These up here, these small numbers all represent the flap operations. The deep flap that I mentioned, we'll go into detail on, is about 17% of all reconstruction. The Latissimus one that uses both tissue and an implant is about 5%. And then these other ones are those other really very rare flaps that we do, occasionally, once or twice a year type thing. So we're going to start by talking mostly about implant reconstruction, and then we'll switch to the tissue reconstruction options. So in implant reconstruction, why would somebody choose that implant reconstruction? What are the benefits? So I tried to, keep it relatively simple and look at the pros and cons of this type of a procedure. So when a patient is choosing an implant-based reconstruction, that is a too short operation. So it is a quick recovery time. It is quick back to life. If you're an active, working woman or an active mom who needs to get back to, taking care of her household, this is a big benefit. You get to, have a short recovery, short back to life and taking care of what you need to take care of. There's no loss of any other tissues and no scars on the rest of the body. So it's a procedure that can be really just focused on the chest area, and that's it. I would say the cons or the risks of implant-based reconstruction are almost all related to the implant itself. Implants are man-made products. They may leak, they may rupture, or the outer lining around that implant might break. The body can sometimes form scar tissue around the implant as a reaction to having that foreign body in there. That we call capsular contracture, and it's basically just a fancy name for scar tissue. Also, one of the risks of having implant reconstruction is having visible rippling or wrinkling of that implant externally when you're looking, at the skin. And it can be very hard to match a natural breast. Yeah, an implant is very perky and has a particular shape to it, and natural breasts are often more naturally sloped, so they're difficult to match with an implant. Another question that implant patients will often ask me is, implant reconstruction, can we do it all in one? That would be ideal, right? A patient comes into the operating room, they have their mastectomy, and we put in their permanent implant, just replace the breast gland with an implant, close them up, and they're all done in one step. So I think that is ideal, but unfortunately it's not as common as you would think. This is a slide to illustrate what I think about when I'm considering doing that single stage or direct to implant versus using a two-stage approach, which is using a temporary tissue expander first, and then later swapping out that temporary device for a permanent implant. So somebody who's an ideal candidate for that one-step procedure where you come in, have your mastectomy, go straight to an implant, is somebody who has a really healthy skin envelope. So they're not a smoker, they don't have stretch marks, they haven't had radiation, they're not diabetic. They also have to have a fairly small to moderate breast size because implants themselves only come in a certain volume. So the biggest implant that we make is 800 cc's. And, 800 cc's, depending on the patient, is probably about a D cup. If a patient's larger than a D cup, a double D or triple D, they likely cannot reproduce their breast volume by going straight to an implant. If somebody would like to do a nipple sparing technique, if we want to do a direct to implant, we can probably match their current volume and maybe go a little bit smaller, but there are some restrictions on how much we can do as far as volume goes. And the skin sparing technique, which takes the nipple, is it will also take with it some skin. So it makes that skin envelope smaller. So if you're going straight to an implant without a stretching phase with that tissue expander, you are likely putting a smaller implant in than the patient's current breast volume. So this goes back to really talking to your patients about what their expectations are, what their desires are. If you have a patient who's a small B cup breast, but she wants to be a full C, we're never going to put a single stage implant in there. We definitely have to stretch that skin to safely get her to her final reconstruction. So these are the things we consider for that option. The other thing to decide about implant reconstruction is if that implant is going to go above or below the pectoralis muscle on the chest. I have some diagrams illustrating what that looks like. And I'll start by saying that below the pectoralis muscle or the subpectoral implant reconstruction is the most common way that implant reconstruction is done by far across the country. The way that we do that is after the breast is removed, I lift up the edge of the pectoralis muscle here, make a little pocket underneath and slide the tissue expander device underneath. This is it on cross section here where you can see the muscle up above and the tissue expander underneath. The bottom part here under the pectoralis muscle coming down to the fold underneath the breast, I sew in a little piece of a supportive tissue matrix. There's a bunch of different brands and companies that make different products for this, but it doesn't really matter what you use. It just helps support that implant in place or that expander in place. And then here you can see there's a little valve here that we slowly increase the volume of that tissue expander. And once it's stretched out and everything has settled down, we can then take the patient back to the operating room, take out this temporary tissue expander, and put in the permanent implant. That permanent implant is going to live underneath of that pectoralis muscle. There's another technique that's newer. I would say the last 5 years has really kind of taken off. And this is called a pre-pectoral implant reconstruction or above the pec reconstruction. Here in this diagram, you can see that the implant is put directly onto the pectoralis muscle and the top covering is that acellular dermal matrix that we were using on the prior slide just to cover the bottom portion of the implant. So the top of this implant is, directly on top of this muscle. There's benefits to doing this approach. The biggest benefit is that when you, I'm going to go back a slide. On this slide, when you contract your pectoralis muscle, you smush down that implant and it can often distort the chest and kind of push the implant out or down. We call that animation deformity. In this patient, if she contracts her pectoralis muscle, the implant might jiggle a little bit, but more like what a natural breast looks like. So this is with the above the muscle reconstruction, there's no animation deformity. It also is a little bit less painful to recover from, a little bit faster of an operation, but minimally so. The downside of doing this is that this implant is directly underneath of the skin, right? There's not a lot protecting it. So on the example before, you can see this nice gradual takeoff of the muscle helping to camouflage the top of this implant here. On the side here, there's not much doing that. There's just the patient's skin. So the implant shape is much more visible here, and there's a lot of what we call superior shelving. You might see that rippling of the implant as well. So I tend not to do this in a first stage for a patient unless they have very thick mastectomy skin. This is a close-up of the tissue expander device. This is that little port I was talking about that can be accessed with a needle through the skin. You can insert the needle into this port. The metal disc here stops it from going all the way through and into the lungs or wherever. And as you hit that metal disc there, you inject the saline and saline goes in and starts to fill this little balloon up. So this is the expander device, which is temporary and does the stretching later to get replaced with a permanent implant. The implants come in a couple of different shapes and sizes. Saline implants were the first type of implant to be developed, followed quickly by a silicone implant. We also have anatomic or textured implants. The difference between these implants are filled with salt water, saline. These other two are filled with silicone gel. The difference between this and this is the shape of the implant. So this is a smooth, round gel implant. This implant is trying to look more like a breast, but it's textured and it has to stay in place. It's a stiff type implant. And unfortunately, these implants have pretty much been taken off the market. There was a very, very small percentage of patients that had textured implants in place, usually from one particular company that developed a cancer in the lining around that implant. So the implant itself seemed to be associated with developing a lymphoma forming around the implant. So the FDA removed these implants from the market. Luckily for me, this is my implant of preference. So I was never really involved in putting in a lot of these implants, but I am involved now in taking some of these implants out and treating patients who have developed that cancer. So we'll move on to shift gears a little bit, show you some patient illustrations. This is an example patient of mine who had a nipple sparing implant reconstruction. So this patient here had a BRCA gene mutation. She did not have cancer. She's very fit. Her nipples are in a good position. She's a small breasted woman. She wanted to be a little bit larger. So we did a 2-stage approach on her. We made an incision under her breast down here. The breast surgeon took the breast gland out on both sides. And then through that incision, underneath of her muscle up here, I placed her tissue expander. We stretched her out over the course of several months and then brought her back to the operating room when we went through that same incision underneath the breast, took out her tissue expander and put in the permanent implant. So she has a smooth round gel implant in place. And this is her final reconstruction. Now, I would like to say that everybody I operate on looks like this, but it is not true. This is a very good, very, very good result. I think everything aligned, the stars aligned for this patient. But this is what we strive for in reconstruction. I would gather that even a plastic surgeon looking at this patient might not realize that she's had her breast removed for the BRCA gene and has had a full breast reconstruction. This is another patient who we did a different approach on. She had a skin sparing mastectomy, so her nipples came off. She was obviously an athlete, so she's extremely fit. And this patient refused to allow us to put her implant beneath her muscle. She's somebody from very, very early on in my career. And one of the few times where I actually used one of those anatomic textured implants because this patient wanted that natural slope up top. So she had a mastectomy through this central incision that took her nipple and areola off. The breast tissue came off. And then after that, I put this implant in place, did a complete coverage of the implant with that acellular dermal matrix, and we closed her incisions. She did not want nipple creations later or nipple and areola tattooing. And this is her about 3 years out, very happy with her results. So I'll just touch a little bit on the Latissimus flap, which is the kind of the hybrid flap that uses both your own tissue and an implant. I think that this is a good option for patients that have a history of chest wall radiation, but still want the look of an implant. The reason for that is if you've had radiation to your breast in the past for a breast cancer treatment that you had, say 5 years ago, a patient had a cancer, they had a lumpectomy and they had radiation. 5 years later, their cancer returns. At that point, they need a mastectomy, but the skin and the chest of their affected side has been radiated. That radiated tissue does not interact well with an implant. So that is often the case in which I'm offering this patient, let's swing around some of this skin and muscle from the back to the front, because this skin and this muscle have not been radiated. So it'll bring healthy, non-radiated tissue into the reconstructed area and kind of wrap that around the implant, allowing the patient to have an implant reconstruction, but still in a safe way in which the implant and the radiation won't have negative effects. Now, this muscle is a very reliable flap. And has a great blood supply to it usually, and it's a little bit of a longer initial operation, but I think that it's really a workhorse when it comes into negating the effects of radiation if a patient wants an implant-based reconstruction. This is just a little bit of anatomy here. The latissimus muscle is shown here. It's actually has a bunch of synergistic muscles that help. It's actually a muscle that works your shoulder mostly. So if you're at the gym and you grab that bar above your head and pull it down behind your head, that's the lat pull. That's the muscle that we're talking about. There are other muscles that take over for the latissimus if it is cut and moved. So it doesn't function alone. There's other muscles that do that same muscle function, and they can get bigger if you've cut and moved your latissimus, but there can be some residual weakness or tightness with that movement. So I often ask patients, what's your dominant arm and what type of sports do you like or activities? Are you a tennis player, a golfer, a skier, somebody who's really using that shoulder strength quite a bit? Kayaking also does it, rock climbing, which is less common, but one of those things that they may not want to move their latissimus muscle. So this is where the patient discussion comes into play. And this is an example patient of mine who had radiation on one side and a bunch of breast scars on the other. She had a gene mutation and wanted to move forward with a completion mastectomy on both sides. So she'd had, you can see all these other scars that she's had. So she wanted to move forward with not having any further biopsies or scares about breast cancer. And because of her history of radiation, we decided to do the latissimus flap. So now she's had from her back, I'll show you her back slide here. You can see her back incisions. That's the incision where we took the little island of skin. We made tunnels around here. We wrapped her muscle around to the front. And going back to the previous slide, this is the skin from her back. I later made her nipple and we tattooed that area, but a lot of her natural breast skin remained. So, and underneath of that muscle sits her also an implant. So that gives her the volume and the look that she was looking for. Our last, kind of category of reconstruction is the flap reconstruction options. And, there are some benefits in general for making a breast out of your own body's natural tissue instead of using an implant of any kind. And I have a similar slide here that I did for the implant reconstructions looking at risk benefits. The benefits of making the breast completely out of your own tissue is that there's no implant. So all the risks on that other slide that were associated with the implant, they all go away. It's a very natural looking result. It ages well with you. If you gain weight, the flap will gain weight. If you lose weight, the flap will lose weight. So it really does it's a long lasting, good symmetry aesthetic result. And then with the ones that take the that lower abdominal fat, which I'll demonstrate a little bit in a minute, those also give you kind of an improved abdominal contour. I reluctantly do not want to call it a tummy tuck, but it's the same sort of thing that you get to use that extra redundant tissue of your lower abdomen and make a breast out of it and get yourself a better abdominal contour here. Now, why wouldn't somebody want to do this? Use your own tissue? It's a really long operation. It takes like almost all day to do these procedures. There are more scars on the body. So you have a big, long scar hip to hip, and therefore a longer recovery. And with some of them, there's a possibility of having to really move some very big, important muscles. So it's not a freebie, but you're always robbing Peter to pay Paul in some way. So the first one we're going to walk through is the first type of fully, tissue reconstruction flap that was developed in the world. And this is called a pedicled tram flap. This diagram illustrates how we do it. So we use that lower abdominal skin and fat, this stuff down here that a lot of us, including myself, have a little bit in excess. And we keep that skin and fat attached onto the rectus muscle, which runs up and down underneath of here. In this operation, we cut the rectus muscle all the way across and then free it up on the sides so that we can swing it up to the breast area to make the breast. So we make literally a tunnel underneath the skin and push this big chunk of tissue underneath the skin and up into the breast area to form the breast. It stays attached at all times to the muscle, which is attached to the rib cage here and bringing blood supply in and out of this tissue. Down here where we move the muscle from, we have to sew in a big piece of mesh to repair that defect where that muscle used to be. So in the end, you have your breast reconstruction formed out of your belly tissue, the muscle's still attached underneath the skin, and down here you have a piece of mesh. There's a long scar hip to hip like this on the abdomen. So again, the benefits are it's all your own natural tissue. There's no implant. It gives you a natural looking result and can age with you. The downside, and I think specific to this pedicled tram flap, is that we're cutting and moving that entire rectus muscle. That is your six-pack muscle. It's your sit-up muscle. And if you try to do that on both sides, cut and move that muscle on both sides, you literally may not be able to do the action of sit up again because nothing else in your body does that. So you might have to grab the back of your knee with your hand and pull yourself up and literally have to change the way your body moves. So abdominal weakness is pretty much a guarantee. You also could develop a hernia in this area where that mesh is sewn in place. And then another thing could happen is something called fat necrosis, where part of the tissue doesn't get a good blood supply as it needs, and part of that tissue dies. So it is a great operation developed in the 1970s. We did it for a long time, but it has a lot of downsides, mostly associated with the way we move that tissue, taking the muscle with us. This is an example patient of mine. She insisted on this operation. After a lot of education and consent with her, we moved forward with it. So she had a bilateral mastectomy. We did a bilateral tram flap operation. I later did a revision surgery on her and made her a nipple with a little bump, and then we tattooed her nipple and areola. So she didn't just go from here to here. These are her interim phases. So this is her right after, is about 3 months after her tram flap operation. You can see the nipples are still, the nipple area is kind of down a little bit. So I did a revision to get her to here, where I lifted this skin up and I made these little bumps here that we later were able to tattoo and turn pink. So in the end, this is her result before and after. This is a long, I want to say she's probably 10 years out from her operation in this photo. And you can see her scar if you look real carefully, from hip to hip. Right here is her scar, and a little scar around her belly button. But this is a flap that's gained weight with her and has lasted her for 10 years with no revisions. She's very, very happy. But how do we get away from taking all that muscle and really damaging the muscle in order to move the tissue that we want for the breast reconstruction? For the breast reconstruction, we really just want the skin and the fat. We don't want the muscle. The muscle is just being used as a blood supply. So the perforator flap is addressing this concept. So the definition of a perforator flap is flap reconstruction technique that moves skin and fat attached to a perforator blood vessel, usually a single blood vessel, leaving the muscle in place. I'll illustrate it here. So previously we thought, like with a pedicle tram flap, that we had to cut and move the muscle in order to move this fat and skin in the way that we wanted to. But as we learn more and more about the anatomy of this area, we realized that the way that this works is there's some big blood vessels that run underneath of the muscle, and they sends up perforating blood vessels through the muscle and into the fat and skin up above it. And if this perforator blood vessel is big enough, I can actually dissect it out from the muscle, follow it down here, and clip it off. Then I can slide this blood vessel literally through the muscle and keep that muscle in place on the abdomen so it can do what it was meant to do. So the muscle remains in place, it performs its normal function, and this concept really minimizes donor site morbidity, where we take that muscle, where we take that tissue from. This is another illustration of it. So these are the blood vessels that are behind the muscle here. This is your rectus muscle, that six-pack muscle. The deep inferior epigastric vessels send up perforators through the muscle up into the fat and up to the skin up above. This is another demonstration of it. Sometimes they go straight up, sometimes they go at an angle, but either way, I can split and remove, like dissect these blood vessels out and keep that muscle in place. As another way to look at this, similar to how we looked at the tram flap, we use that exact same lower abdominal skin and fat. So it's that same kind of extra stuff below the belly button. And this is a see-through anatomy here. So here's your muscle that you can see running up and down here. These are the deep inferior epigastric blood vessels coming off of the main system here in the deep groin. And they come up, they give off these perforator blood vessels. Okay. And I'm finding one of those during the operation and dissecting it out. So if you look back here at the belly, I've dissected out the blood vessel. Oops, sorry. Sorry, wrong direction. So I've split the muscle along its fibers, but I have not removed it. All I've done is remove the skin, the fat, and it has the blood vessel attached to it underneath. Now it's free. I've lifted it up and off the patient. It does not have a blood supply. So the biggest part of this operation is taking that tissue and then reconnecting it to the blood supply up in the chest area. So that's when microsurgery comes into play. So we, up here in the chest, I take out a small portion of the rib here, and I find a similarly sized artery and vein that are running up and down here on the chest wall. Underneath of the microscope, I take the vein from the chest and sew it up here to the vein of the flap right here. And then I sew the artery to the artery. So what that allows to do is blood comes in through that artery, it supplies the tissue of the flap, and then comes draining back out through that vein. So it's basically just like an extra plumbing circuit that I made to come out to give blood supply to this tissue and come back. But it's a really delicate thing to do. We sew these blood vessels together with suture that is smaller than a piece of hair. So it's a very tiny suture material underneath of a microscope. After we've moved the tissue and hooked it up to its blood supply, we then shape it to look more like a breast, and we can tuck it underneath of the skin of the breast skin that's left behind. So all of that delicate microsurgical anastomoses are happening up here underneath of the skin. The flap has now, you've removed the breast and filled the breast skin envelope with your fat from the belly and kept that one little piece of skin here that used to probably be down here on her abdomen. So what are the benefits of doing this? I think we've talked about most of them already. The biggest benefit of a deep flap surgery or a perforator flap surgery is preserving that abdominal strength. The strength of the abdomen, the rectus muscle works at about 70% function. It's not perfect, but it's much better than 0 when you cut and move the tissue. So it works at about 70% function. There's also a much, much lower rate of abdominal hernia or bulge. It's less than 1% versus up to 15% in those tram flap operations. And then you also have those benefits of the improvement of the abdominal contour and, less pain, faster recovery, et cetera. But the biggest benefit, again, is in maintaining that rectus muscle and your abdominal strength. So who's the best person to have the ideal deep flap candidate? And I would say that is probably somebody who's relatively young, because the flap is going to age with you. And there's really no lifelong risks of those implants. Now, that being said, I've done flap surgeries on patients in their 20s all the way up to their 70s. So I don't have an age cutoff. I would offer a flap to someone who is, relatively healthy enough. It is an ideal person is somebody who's pretty active, because those perforator flaps help preserve your natural function of your muscle. You need to be healthy enough to be able to tolerate a longer procedure. And, this operation takes, again, all day long to do. And I think is very helpful, especially in patients who need or want bilateral breast reconstruction. Very popular in patients who have a gene mutation and don't have an active cancer, but are choosing to have their mastectomy for risk reduction and want a natural or a lifelong solution for breast reconstruction. So that to me is the ideal patient, but there are, sorry, one more thing is that patients also, need to have the appropriate body habitus. So the skinny minis do not have enough tissue here for me to make a breast out of. So they need to have the same proportion of tissue on their belly that they are going to be okay with their breast size. So they need to have that amount, that ample tissue in that lower abdominal area. But there are some people who should not have a deep flap. And I think long and hard about this before surgery, so we don't get ourselves into a bad spot after or during surgery. So someone who's an active smoker is not going to have a deep flap. They're at high risk for having all sorts of complications with this big procedure. Anybody who's had a blood clot in their leg or in their lung, or some kind of known hypercoagulable state, so they know that their parents formed blood clots and they're prone to it, they probably should not have a deep flap, because that tiny little blood vessel that I sewed together, if it clots off, the whole flap dies. Anybody who definitely needs radiation therapy after their mastectomy should not have a DIEP flap first. I don't want to radiate that flap. So I would often put in that temporary device with the tissue expander, allow the patient to get their radiation, and then later do their DIEP flap. There are some patients who have allergies to anticoagulants like aspirin or heparin. We use those during the operation, so they cannot have this operation. It's important to really give a patient a clear idea of what their post-operative care is going to look like. They are going to need some help at home. And there are people who just can't manage that. They live by themselves and they have no one who can come and help them or can't afford to hire, a aide to come and stay in the house with them. So you need to be able to have some support after this operation. You also need to be able to understand the scope of the operation. So there are some people, very rare, but people who just cannot understand how big of a procedure it is. And, therefore really just have, I think, unrealistic expectations of what it's going to be like. And, if I can't come to, a consensus with them, we may not be able to offer them the operation. If you, are a sicker patient, you have active cardiac disease or other risk factors. If you're using steroids, you won't heal well. If you're currently using drugs or abusing alcohol, it's also a contraindication to this operation. Other things that are more softer calls, the BMI is a body mass index. It's a calculation of height and weight. And the higher it is, the heavier a patient is often. And so if a patient has higher than 35 BMI, I'm often think that they are more high risk for having complications. These are more softer contraindications, but we talk through them. If a patient has metastatic disease or breast cancer that's spread throughout their body, this might not be the best operation for them. Metastatic disease puts you at a little bit higher risk for forming a blood clot. So again, might not be the best solution. And some people just have poor anatomy that doesn't line up well with this type of a procedure. I put these in the risky category as well. Diabetes or autoimmune disease, somebody who may have had radiation or other surgery on their abdomen, somebody who's stopped smoking recently, but we have a hard and fast rule about abstaining for 6 weeks before and after surgery. And I actually urine nicotine test patients to make sure that they're able to be honest about that. And caffeine, they need to hold their caffeine around the time of surgery because that also is a vasoconstrictor. So there are some people who are risky populations, but in the end, I think it's a great operation for a certain population that can get great benefit from having this procedure. And at this point, I'm basically just going to run through a bunch of examples for you of some of my patients. We're getting towards the end here. This is what I would call a fairly typical result. This is a patient who had a bilateral mastectomy. She had skin sparing, so her nipples came off. We did a bilateral DIEP flap reconstruction. I made her nipples later with a little bump, and then we later tattooed her. This is old tattooing technique, not our new tattooing technique, which I'll demonstrate to you later. This is a patient who came to me. She's HIV positive, and she was told by 3 surgeons that she couldn't have a DIEP flap because she is too high risk. Now, there is nothing about HIV that makes you hypercoagulable or anything that should put her at risk for having that procedure, and she's a perfect candidate from an anatomy standpoint. So this is her result about 7 years after her surgery. She's gained some weight, and you can see the flaps are probably bigger than what she actually originally donated. We made nipples for her. She didn't want tattoos because it was against her religion, but she is thrilled to death with this result. This is a patient who came to me from Florida. She had 33 operations on her breast trying to do an implant-based reconstruction. So you can see they even at some point made her nipples and did tattooing up here, but she got infections and the expanders came in and out and back and forth and, tried to do different procedures on her. And in the end, she lost her reconstruction, her implant reconstruction. She just couldn't do it from an infection standpoint. And her surgeon in Florida told her because of her abdominal scar here, She couldn't use her belly for reconstruction, so she had to live like this. So she came to me in tears saying, I look like a fat man. That's how she described herself. I want to look like a woman. So we did a CAT scan. We looked at her blood vessels. She had beautiful perforators here. We split this muscle in half right here. We split this fat in half and used half to make one breast, half to make the other. So this scar here had nothing to do with her ability to have this surgery. So you can see we've kind of tightened her up. Long scar from where we took this tissue out and ultimately made her nipples and did her tattoos. This is another complete delayed reconstruction patient. She'd had radiation in the past over here and just chose not to do reconstruction at the time of her first surgery. And we did a bilateral. She did not have nipples made, but instead had a 3D nipple and areola tattooing with that newer technique. This patient I would call an implant cripple. So this is someone who's had implant-based reconstruction after a mastectomy. She's had radiation, and you can just see how tight and cold and hard that implant is. This is not going to last here long. She just wanted it taken out, but she heard about this deep flap and wanted to come see me about it. We took her abdominal tissue, made her a breast mound. This is a picture before we did her nipple creation and her tattooing, but quite a drastic result for her. Another patient who really wanted to try to match her natural large ptotic, droopy is another word for ptotic breast, as best we could. And so, we shaped it as best we could to match her other side. And I think she's had a small lift on this side in the end. This patient had horrible radiation burns from her treatment. She had had an attempted a tissue expander implant, which failed and was taken out. And we were able to take all of her abdomen and reconstruct her breast mound. This patient is a police officer, very, very active, did not have a lot of extra abdominal tissue, but we did a unilateral reconstruction on her. This is her reconstructed breast where I made a nipple and we tattooed. This breast is her natural breast, just lifted slightly. Another unilateral one-sided reconstruction on this patient here. She has a larger kind of skin paddle from her abdomen, which sometimes we need to do. We did a small lift on the other breast to get her more symmetric. A patient for a bilateral reconstruction. Again, you can kind of see that pale skin paddle around here. That's from her belly, but she did that 3D nipple and areola tattooing, very realistic look. This patient is also a bilateral reconstruction, a larger volume reconstruction with created nipples and tattoos. This patient was a stressful procedure for me. She had had a failed implant reconstruction. She has a scar going this way, a scar going from here all the way down like this. She had a port in place here and her chemotherapy infused into her skin. It leaked into her skin and she got this huge burn here and lost her implant reconstruction. So she came to me with radiation, all the scar, and she wanted a deep flap. She also had a known genetic propensity for blood clots. So we put her on a blood thinner drip during her operation, and she ended up doing well with this. We took as much tissue as we could and gave her this reconstruction. Another patient who I would call an implant cripple, both sides. This side had radiation. This side was just a lot of that scar tissue, capsular contracture, tightened up, bilateral deep flap with nipple creations. This is a patient who we moved her tattoo up to the breast area, so you can see the tissue we needed to move. And she loved having this last little limb of her star down there on her belly. Another very large volume patient where we took these implants, these are both implants, out and replaced them with abdominal tissue for a softer, more natural looking reconstruction. Another contracted, radiated implant. You can see a theme here of patients not doing well with radiation and implants, and getting a much more improved contour and shape and volume with using their own tissue. This patient, also near and dear to my heart, she had a genetic propensity for cancer, but not an active cancer. And we did a CAT scan on her to look at her blood vessels for a potential deep flap. And as we did that CAT scan, we found unbeknownst to anyone, a kidney cancer. And so she was otherwise perfectly healthy, but we found her kidney cancer, and you can see here she underwent a nephrectomy, and her kidney cancer was a cure for her. And about 8 months later, we did her DIEP flap surgery. Her DIEP flap surgery was performed in a nipple sparing fashion, so you can do these procedures through the incision underneath the breast and just stuff that flap up and into the breast area, doing your microsurgical anastomosis here. And these are her natural native nipples there. And this is my last example patient. She's also a nipple sparing procedure. Same idea. Through the inframammary fold here, we gained access to do the mastectomy and do the microsurgical anastomosis and moved her abdominal tissue up to the breast area. And that's her scar. So the last little bit of this talk, I'm just going to talk a little bit about our nipple and areola reconstruction and tattooing, which is something that is, relatively new to this area. And my PA, who I work with every day here in the office, Carrie Gregory, she is specially trained on these techniques, and she is the person who does the nipple and areola tattooing for our practice. And I'm going to show you some of her results. So sometimes a patient may choose to have a nipple created by me as a surgical procedure and then have a tattoo. So this is a patient who chose that. The nipple creation is, diagrammed here, where we make a little incisions on the breast skin. We lift that skin up, we wrap it together and suture it together to make a little bump that sticks out. So it's kind of like skin origami. So we do this little bump creation, and then Carrie does the nipple and areola tattooing. This is a patient who did not have a bump made, but instead just had the nipple and areola tattooing. So there is no bump of a nipple on this patient. This is pure tattoo ink, giving you the look and, visualization of a 3D nipple. So she is a smooth canvas, and this is what the final result is for her nipple tattoo. This is another 3D tattoo patient. So this is her before her surgery, this is her tattoo, this is her afterwards. Very realistic looking, and you can see here no bump. It's actually smooth, even though it looks like one. Our tattooing process is pretty straightforward. We have a multidisciplinary clinic where Carrie does the procedures. She consents the patients, she does photos. Together they pick where the nipple is going to go. They pick the colors together for the exact nipple and areola shading, and then we'll do photos at the end of the session, and she'll give you your instructions. This is a patient who was coming in. These are, you can see here, the sample pigments that she was putting next to the patient's native areola to pick the pigment color. She drew on the patient where they're going to put the tattooed nipple, and she brought her granddaughter with her to help her pick out colors. And here's Carrie performing the procedure. And this is the patient's final result. So again, there is no bump here. That's all 3D tattooing. So I think a great option for our patients. So this is a demonstration of that first patient from beginning to end, showing one patient's experience. She underwent a right-sided mastectomy. She had a tissue expander placement. She came back to the operating room where we took out that tissue expander. We put in her permanent implant. We did a small implant here. On this side, we later created the nipple with that nipple creation technique I showed you. And finally, she got her tattoo from Carrie. So this is her final result. So from beginning to end, one patient's experience. And I think that pretty much sums up it, my talk. And I think I've given you a pretty good illustration of what motivates me, gets me out of bed in the morning. And I'd like to just emphasize with one last comment that this is not, a one pony show here. This is something that happens in a group. These are a lot of my colleagues here at the Helen F. Graham Cancer Center. Our last cancer update newsletter last November was all about breast cancer. And, we were all highlighted in this newsletter. One of my patients gave her a description of her journey. to the newsletter, and Carrie's tattoo techniques were illustrated. So I'm honored to be able to work with this group every day, and we've grown even since this photo. We have people who are missing, so time to update the photo and also take any questions that you all might have.
That was fascinating. And in the chat, people keep saying like, thank you, you do such great work, you know, you're wonderful at what you do. Thank you, thank you, thank you. But we also have a lot of questions.
Okay.
Shocking. I know this is a good group for questions.
Would you prefer I switch to my phone with the video? I can do that if you want, since I'm not showing slides anymore.
It doesn't bother me. You
Okay.
do what you like to do.
All right, fine. We'll skip it. Let's just
All
go.
right. They can look at my ugly mug. It'll be fine. All right. First question. How many years of school and residency did you do before your first job at Boston?
That is a great question. So do we count kindergarten and no nursery school? I don't know. So I went, through high school, typical. And then I did 4 years of college where I did my bachelor's of science in aerospace engineering. I did 1 additional year where I got my master's of science for aerospace engineering. So that's 5 after college. Then I did 4 years of medical school. So that's 9. Then I did a 5-year general surgery residency program. So 14. After that, I did 2 years of plastic surgery fellowship, followed by the 1 year of microsurgical specialty. So 17 years after high school until I got my first job.
Yeah, until you got your first real grown-up job.
First real grown-up job
after high school. There you go. How often does an implant need to be changed?
Well, there's no hard and fast answer on that. The companies tell us to expect that they're going to last about 10 or 15 years before we'll need to do some sort of a revision, but there's no real maintenance surgery. So you don't have to do surgery on a patient if you're seeing them and everything looks healthy and there's no scar tissue building up and no asymmetries developing. You don't need to do maintenance surgery.
Okay. How often do you see patients who want breast reconstruction, but not because they're suffering from some sort of medical issue, but because they have a desire for their breasts to look different? And then there were a couple of questions that I'm lumping into this question. For example, people who have weight issues, people who want to have gender affirming surgery, non-binary folk, that type of thing.
So it's a great question. In my specialty here, I have focused mostly on active breast cancer patients or people who have a history of breast cancer or a genetic propensity for breast cancer, like the BRCA genes and such. But there are definitely patients who undergo, a breast reconstruction or a breast shaping or altering surgery for those other reasons. In the past, I've done them, I'm trained in those techniques, but that's not, we just don't have capacity, here at our center right now to do that because we need some more plastic surgeons. I would love to be able to increase that as we go, because a lot of those surgeries, especially the 2 you mentioned with a massive weight loss patient or gender affirmation, those surgeries originally were not covered by insurance and now are. So they are considered a reconstructive procedure, not a pure cosmetic procedure. Although, I think you get a feel for me and my MO, and that everything to me is a cosmetic procedure. I'm not, I don't really delineate between the two. For me, cosmetics is aesthetics. It's what I want the patient to look like. So, but, luckily those procedures are now covered by insurance, often, and are something that can be done. I don't do them as often, but potentially we could grow our center here to include that patient population.
I'm sure that would be wonderful. And then since you spoke about insurance, what about those people who maybe aren't covered by insurance? How would they go about getting this type of procedure?
The Helen F. Graham Cancer Center has a lot of options for patients with that. We have people who worked specifically in social work who can help get patients insurance, either through the state or through the government. And there's also temporary funding for patients that can be, last for, a year or two to cover their cancer care. To tell you the truth, I struggle a little bit with that because the things that I do, and one of the points that I should have made during the presentation is that your breast reconstruction is usually not a once and done, surgery. It's multiple stages and multiple procedures that are usually spaced out, at least 3 months apart. So you're, from start to end, it's usually about a year from when I meet you until we're starting, your nipples are tattooed and we're done. And then we do annual visits once a year to check in on you. So I don't know that it's really even ethical to give a patient, a temporary insurance coverage for 1 year and then say, I'm putting an implant in, I need to see you every year, but you can no longer come back to see me because you don't have insurance. So, for me personally, I'm happy to write all that stuff off. I don't, care one way or the other about that, but, we really work towards helping patients get into a situation where they can at least get, minimal insurance that can cover some of the basics when they're done with the big surgical procedures.
I like that idea. I was always the doctor who was like, yeah, sure, give me a bushel of apples, we'll call it even.
I love it. Yeah.
Do breast reconstruction significantly affect breastfeeding? And then there's a question, is that one of the reasons that doctors do not support getting the reduction? So I don't know if you want to answer the second part, but do breast reductions significantly affect breastfeeding?
So if you're having, there's kind of two separate questions. And I think maybe mixing up the terminology of reconstruction versus reduction. A breast reconstruction procedure is often and most usually performed after a full mastectomy. So the mastectomy happens, the breast gland comes off, and then I recreate the breast out of whatever it is, the implant or the tissue. So that implant or, abdominal fat will not allow you to breastfeed. So there was absolutely no breastfeeding after a mastectomy on that breast. If a patient chooses unilateral, that might be different for the other breast. Breast reduction surgery, though, which could also kind of be lumped into some of that oncoplastic techniques I talked about. So if somebody needed, they had a lumpectomy for breast cancer and then, radiation. Sometimes I'll do that tissue rearrangement to get the breast in a better shape. That's similar to what our breast reduction techniques are. With that, you're leaving behind breast tissue. Your breast is still made up of your breast gland. It's just rearranged a little bit. So reduction procedures, patients can breastfeed after those procedures. It may be a little bit more difficult because there's additional scar tissue. Some of the breast gland has been disconnected from the ducts that, come out through the nipple and areola. So you might not be able to, breastfeed to the volume that you would have before, you had that surgery, but you certainly should be able to breastfeed if that nipple is still attached to breast gland. Does that make sense?
It does.
Great.
I'm going to skip that question. When you say you check for a patient's full understanding of the situation, how do you go about scanning for that?
It's really spending that time with them. You see who's with them I always ask who's with you at home, what type of activities do you do, what's your social support, and trying to get an idea of kind of what their social, support system is at home. And then, talking through the procedure and the details, I keep it as simple as possible, but it's a complex issue, I mean, you can see all the things we touched on tonight. I mean, I could give you I could talk for another 24 hours about details about what we could talk about breast reconstruction. So I have to kind of simplify it somewhat. But if I sit there and clearly tell them, listen, you have a clotting history, you've had a DVT and your mom died of a pulmonary embolism, I believe you're high risk for this operation. And I don't think it's a good idea for you. If, in the next, minute, the patient says to me, but, I think I'm a good candidate for this operation and it should have no complications, right? If they're kind of giving me those feedback indicators that maybe they're not hearing what I'm saying or understanding the risks I'm trying to illustrate, it's that's not real specific for you, but that's kind of how we suss out, who's really able to gain a clear understanding of this and who's not?
I think that's all the time we have for questions since it's 8:33. Dr. Caterson, what we did last week, if you're up for it, is that there are still questions that have not yet been asked. Can I send them to you in like Word document form, and you can fill them out and get them back to us, and we can put them online? Is that okay?
Sure, yeah, absolutely. I'd love to.
Right. Fantastic. Well, everyone, that is it for today. If you're still calling in and you haven't emailed me, the word of the day was cats, C-A-T-S. And next week, we are going to be talking with Dr. Brad Sandella about sports medicine. So thank you again, Dr. Caterson. That was awesome. I was riveted the entire time.
Thank
and,
you. Thanks for the opportunity.
I hope everybody has a good week, and we'll see you on Thursday.